My name is Mark Quigg. I'm a professor of neurology at the University of Virginia. We surveyed a group of adult patients with epilepsy, and the survey included questions on their seizure status over the past 4 weeks and asked about which medications they were taking for epilepsy and a variety of scales used to measure quality of life, depression, sleepiness, mood, and a couple other variables like unemployment, age, gender, etc. We divided the patients into 2 groups, those who are on more than one anticonvulsant and those who are on just one anticonvulsant. And we compared the 2 groups. So the patients taking polypharmacy, more than one anticonvulsant, all the sleepiness and tiredness variables that we measured didn't really pan out correlating with polypharmacy or monopharmacy. Polypharmacy did correlate with worse quality of life scores. The lower proportion of them were seizure-free. That patients on polypharmacy were younger, that patients with polypharmacy had evening-weighted sleep-wake schedules, meaning that they tended to be night owls, to prefer to be up at night and asleep during the day, and had a lower rate of employment. We then evaluated the kinds of anticonvulsants they were on and tried to make associations between the different kinds of anticonvulsants people were on and quality of life and polypharmacy. And none of the medications had any clear associations with either quality of life or with polypharmacy. Finally, we took all those variables and took the significant ones and put them in a statistical model that could account for their seizure status, so throw that away as a confounding variable. And what we found was clearly lower quality of life was associated with polypharmacy regardless of seizure status, and that the only important variable from our survey section that stood out as an association with quality of life remained to be unemployment. We were quite surprised that none of the sleepiness, tiredness, depression markers had any association with polypharmacy. So that was our surprise finding. And I think that unemployment in this particular case isn't the real variable, it's not the real cause, it's a surrogate marker of overall patient function. And so that makes sense when you're measuring quality of life. I think the clinical take-home question is, of course, we have to use more than one medicine if we're pushed in order to meet goals of seizure remission. Because clearly seizure remission and quality of life have strong correlations. But I think the take-home message is that there's a cost to that use of polypharmacy. And as at least if one is aware of this set of associations, you can go forward knowing the risks and benefits that you're exposing the patient to.